Hi folks, well, welcome to 13-4 and 13-5. A lot of anatomy in this section, and I won't be rehashing through all the anatomy. You have it in lab. I do want to point a few things out. So basically what we're covering in this section is we're going to cover the architecture of a nerve, and I'm using the word nerve specifically, not to indicate a neuron, but a nerve, which is thousands of neurons. And then we'll look at some neuronal pools of interneurons, and that's probably the most important part of these sections. So let's get started here. This is the architecture of a nerve, and we will do this in lab, but I would still like to point a couple things out, and that is this. Let's start from small and go to big. Notice that each individual neuron, here's an axon of a neuron, and it's myelinated. There's Schwann cells wrapped around it. Notice that each individual axon of a neuron is surrounded by a connective tissue sheath called an endoneurium. And then notice that there's many of these axons surrounded by endoneurium inside a fascicle. So this is a fascicle right here. Then notice that each fascicle is surrounded by a connective tissue sheath, and this is called a perineurium. And then notice that there's bundles and bundles of fascicles in here. So we have the fascicles all surrounded by perineurium. And then these are all encased in a connective tissue sheath called an epineurium. Now this architecture should sound familiar to you from Bio 203. When you studied the muscle architecture, a muscle organ, you learned an epimysium, a paramysium, and an endomysium. And it's really similar. The endomysium surrounded an individual muscle fiber, a muscle cell, a myofiber. And then the paramysium surrounded a fascicle of myofibers, and then the epimysium surrounded the entire muscle organ. So this should sound really familiar, and you need to know this architecture. This is a true organ. Every named nerve is an organ. Now remember from Bio 203 that an organ is two or more tissue types acting together. Well, where are my two or more tissue types? Well, if you remember your primary tissues, you have epithelial tissue, you have nervous tissue, you have muscle tissue, and you have connective tissue. Well, the only one that's not seen here is muscle. You have epithelial cells lining these blood vessels, so that's epithelial tissue. You have nervous tissue, of course, because you have neurons in here. And you have connective tissue. The epineurium, the perineurium, and the endoneurium is all connective tissue. So this nerve is an organ. That's the architecture of a nerve. Now, our peripheral nervous system is organized in such a way that you can actually name dermatomes and myotomes. We'll talk about myotomes as well. I'll spell that word for you. Myotomes, they're not as clean as dermatomes. What I mean is there's exceptions, and it's just not a clean delineation like there are in dermatomes. But let me show you what the dermatomes are. A dermatome is a section of skin, and it's bilateral. That means on both sides of the body. A couple words for you there. Bilateral means both sides of the body. Unilateral means one side of the body. Contralateral means you cross over. So contralateral actually means the opposite side of the body of whatever you're referencing. Here's this word, contralateral. Ipsilateral means you're staying on the same side of your reference point. So contralateral, ipsilateral, unilateral, bilateral. Some words for you. A section of skin served by one spinal nerve is a dermatome. And this side of the body right here is the front, the anterior side, and this side of the body is the back. And just look at T1. This section of skin is served by the T1 spinal nerve. Let's look at T2. This section of skin right here is served by the T2 spinal nerve. And these are dermatomes. Now, in the middle of these dermatomes, it's pretty clean. That means that in the middle of these dermatomes, only thoracic nerve 1 would serve that area of the skin. Towards the boundaries, it's not as clean. There might be some other nerves serving that area near the boundary. And T1 might delve into the C5 area. That could be true. And you'll see why shortly, because we have plexuses. But in the middle of these dermatomes, it's pretty It's pretty clean that only that nerve serves that area. Because of this organization, when we have viruses, and herpes viruses are famous for this, they hang out in our nerves. And when these herpes viruses come out of a dormant state and they travel along a spinal nerve, you can get lesions that follow that dermatome. And shingles is an example of that. Shingles is the varicella zoster virus, which is human herpes virus. It's human herpes virus 3. There's about 7 or 8 human herpes viruses, and I don't remember them all right now. I can tell you that human herpes virus 1 is uh, the cold sores. It hangs out in the trigeminal nerve. Human herpes virus 2 is the sexually transmitted disease. Human herpes virus 3 is chickenpox. Human herpes virus 4, I believe, is mononucleosis. It's Epstein-Barr virus, and so on and so forth. There's a bunch of human herpes viruses. Chickenpox is one. So you can see a picture of shingles right here, and you can see that it does look like it's following a dermatome, and that's why, because they hang out in these nerves, and then when they come out of a dormant state, they follow along the nerve. All right. By the way, since we're talking about shingles, if you had chickenpox as a kid, then you should get a booster when you're about 60, and that's so you don't get shingles. Now, if you didn't have chickenpox as a kid, likely if you're young, you had the chickenpox vaccine anyway. All right, so that's a dermatome. Okay, myotomes. Over here, you're looking at some myotomes, right in this area. This area is myotomes, not dermatomes. So we're talking about nerves that are serving muscles. That's what we're talking about here. And this is not as clean as the dermatomes, which means that the radial and ulnar nerve, and the median nerve, I can trace this back to a spinal nerve, but not cleanly. And the reason being is because these spinal nerves fuse, and they fuse in these things called plexuses, and you'll see how it gets a little bit messy in a plexus. But you can see some ramifications of these myotomes. For example, the ulnar nerve is the nerve that runs underneath your medial epicondyle of your ulna, and that's the funny bone. That is that protrusion. The medial epicondyle, if you recall, is the protrusion from the medial side of your arm. And when you bang your funny bone, and in other words, you're smacking your ulnar nerve, you will feel the manifestation of that in this part of your hand. Now, it won't be on your thumb, and it won't be on your pointer finger or middle finger, but it'll be on your pinky and your ring finger, and it'll be on the medial side of your palm. So this is why, because you just banged the ulnar nerve, and it didn't affect your entire hand. It just affected this part of the hand served by the ulnar nerve. And these are myotomes, and the ulnar nerve would cause the muscles in these part of the hands to contract. So that's a dermatome, myotome example right there. Another myotome here, looking at the nerves of the lower limbs. So you could have nerves that would serve the muscles of the foot here. The sural nerve would serve this, fibular saphenous. You can see that. And the thing here that I would point out clinically is we have this condition, and it happens to athletes, or actually can happen to anybody, but it seems to happen to athletes a lot when they have blunt force trauma injuries, and that's called compartment syndrome. And what that means is you have a trauma to, say, your leg, your lower leg, and you have inflammation. Well, the muscles of the lower leg are all encased in this fascia, or fascia. Here's the word. You learned that in Bio 203. And as swelling occurs, the fascia doesn't allow the swelling to go anywhere. So internal pressure builds up inside that fascia, and that pinches our nerve. Now, it pinches one of the bigger nerves, like the sciatic nerve, or actually the sciatic nerve would bifurcate by then, by the lower leg. So it would pinch the fibular nerve, the peroneal nerve, or something like that, or the tibial nerve potentially. And then what happens is that nerve is compressed. And when that nerve is compressed, it will be damaged and quit firing. And then you get what you call foot drop. So when you have compartment syndrome of the lower leg, your nerve is compressed and it can lead to something called foot drop. And that means that you can't dorsiflex your foot. And that's actually a sign of compartment syndrome. You ask someone to dorsiflex their foot and they can't do it, it drops, and that's a sign of compartment syndrome. And that can happen when you compress these nerves. You could have compartment syndrome in the thigh, but it's not as likely because the thigh has a lot of soft tissue, whereas the leg does not. And the thigh can withstand a great deal of internal bleeding and a great deal of inflammation before the pressure is put on the sciatic nerve. You can have compartment syndrome in the arms as well. All right, so that's dermatomes and myotomes. All right, this is showing you that the sensory nerves are going in through the dorsal root and the dorsal root ganglia. Matter of fact, the soma of the sensory nerves is inside the dorsal root ganglia. These are sensory nerves going in the dorsal root. They synapse an interneuron in this area, and then the interneuron, the interneuron is going to synapse and fire on a motor neuron that'll leave through the ventral root. So this is showing you the dorsal root ganglia and the dorsal root, and it's showing you the sensory nerves going in. Now let me show you. Oh, before I move on, you're going to learn this in lab, but let me just point that out. Now I'll point out next slide. So that's the sensory nerves going in. They go in from the posterior section to the dorsal root. And then the motor nerves come out the ventral root. And this shows you the motor nerves coming out the ventral root like this. So the sensory nerves, it's not showing you both here. The sensory nerves are going in. They're synapsing in the gray matter of the spinal cord, and the motor nerves are going out. Something very, very cool happens here. If you look at just the visceral motor nerves, and that's this blue one right here. This is the visceral motor nerve. That means an autonomic nerve. That's what we're talking about, the autonomic nervous system. If you look at this autonomic nerve, this travels out through here, briefly in the spinal nerve. This is the spinal nerve right here. And then enters this ramus communicans. Now, this preganglionic neuron of the autonomic nervous system is myelinated. So this is the white ramus communicans because that blue nerve is myelinated and is white. And then it synapses in this ganglia. So this black nerve right here is the postganglionic nerve, and that's traveling through a ramus communicans, and it's unmyelinated. So this right here is the gray ramus communicans as opposed to the white ramus communicans. The white is white because it's it has a whole bunch of myelinated neurons, and the gray is gray because they have a whole bunch of unmyelinated neurons. And when we get to the autonomic nervous system, we will study the routes that these sympathetic and parasympathetic neurons take. So I'm showing you this now, and you will see this again in the autonomic nervous system chapter. But I'm just pointing out the white ramus communicans and the gray ramus communicans because you'll see it in lab. All right, so that's the sensory nerves going in through the dorsal root and the motor neurons coming out through the ventral root. Another picture of the same thing. This is the exact same thing we just looked at. It's just not as busy. So you can take a look at this and make sure everything makes sense to you. Let me point one other thing out. I've mentioned it before. The soma of the sensory nerves exist in this dorsal root ganglia. This is actually exactly where the varicella-zoster virus hangs out. So when the varicella-zoster virus comes out of the dorsal root ganglia and travels through the spinal nerve and outward, it'll travel through it'll travel along a dermatome. And this dorsal root ganglia is where it hangs out. Another thing I want to point out is that the types of neurons that these sensory nerves are unipolar, or what some people call pseudo-unipolar. And you can see that it looks like a pseudo-unipolar or unipolar neuron as well. This is the same picture of the motor neurons coming out of the ventral root, and you can see the white ramus communicans and the gray ramus communicans, also called communicantes sometimes. So there you go with that anatomy, and you'll see that again in lab. This is showing you the pathways. I'm going slow so you can see the pathways. Now let me tell you that it's simplifying the sympathetic route. There's actually 4 routes that the sympathetic neurons can take, and it's not going through all of them right here. It's simplifying it. But that's fine for now that you see that there's different routes these neurons can take. Okay, now it's going to do the sensories. So we just did the motor, now we're going to do sensory. Read the boxes as they fill in. And that's it, folks. So you saw that we mapped the motor neurons first in the case of this little animation, and then we mapped the sensory neurons second. So you can see that. All right, in lab we will talk about. Well, actually, in lab we'll just identify the plexuses. So for the plexuses, we have 4 major plexuses or plexi. I'm actually not sure if what's the better word to use there, plexuses or plexi. But there's 4 major ones. You can see 2 of them here. Let me name the 4 for you. They're the cervical plexus, the brachial plexus, the lumbar plexus, and the sacral plexus. Some people combine the lumbar and sacral plexus and call it the lumbosacral plexus. And you'll see why, because the nerves are all intermixed. The cervical plexus is C1 through C5. Now, that's a pretty easy concept that the cervical plexus is C1 through C5. But the brachial plexus is C5 through T1. So I want you to see that there's overlap there. And actually, the brachial plexus is a little unique because in some individuals, the brachial plexus is C4 through T2. That means you could have a brachial plexus that is C4 through T2, but I could have a brachial plexus that's C5 through T1. But the bottom line is I want you to see this overlap. C5 is shared by both plexuses, so there is overlap in these plexuses, and there will be in the lumbar and sacral plexus. You'll name these in lab. I want to point one thing out here. The phrenic nerve is C3, C4, and C5, and there's a saying for that. And the saying for that is C3, C4, and C5 keeps the diaphragm alive. And the phrenic nerve goes to the diaphragm and innervates it and tells it to contract so you breathe. So the phrenic nerve, C3, C4, and C5 become the phrenic nerve. C3, C4, and C5 keeps the diaphragm alive. The lumbosacral plexus here. With the lumbosacral plexus, you can see how intermixed they are. And in fact, the lumbar plexus is T12 to L4. You can see that right here, T12 to L4. And the sacral plexus is L4 to S4. So you can see the overlap again. There's definitely a lot of overlap with this. Well, not only is there this overlap of L4 with the 2 plexuses, but then if you look up on here on the nerves coming out, you can see that they're intermixed. You can see that the lumbar plexus can add to the sciatic nerve, and the sacral plexus can add to the sciatic nerve, and et cetera, et cetera. So there is some overlap in these plexuses, which, by the way, is why I said the myotomes were not as clean as the dermatomes, and it's because of these plexuses. All right, that's the lumbar plexus and sacral plexus. There's a saying, and uh, the sacral plexus becomes many nerves, but one of the nerves the sacral plexus becomes, which you're going to have to learn in lab, is the pudendal nerve. It's the pudendal nerve and it's in some of its branches that can be nicked during a prostatectomy, a removal of the prostate gland. So if a man has, and only men have prostates, just to remind you, if a man has benign prostatic hypertrophy or even prostate cancer, a malignant prostate cancer, if for some reason the prostate has to be removed, they do a prostatectomy. And now they used to do it manually, and 70% of the time when when a person had prostatic hypertrophy and they removed the prostate, 70% of the time it led to erectile dysfunction. But now they don't do it manually anymore. A robot does it for you. Obviously, the doctor is controlling the robot, but the robot does it. And now, 70% of the time, you don't get erectile dysfunction. You can actually remove the prostate without nicking the pudendal nerve. The pudendal nerve came from the sacral plexus, and it came from S2, S3, and S4. And the saying, and it's a little bit crude, but the saying is S2 and S3 and S4 keeps the penis off the floor. And what that means is S2, S3, and S4 become the pudendal nerve, which hits your external genitalia. And of course, that innervation can lead to erections, or if there's damage to it, it could prevent erections. So that's the erectile dysfunction and prostate story coming from the sacral plexus. This is a blown up picture of the cervical plexus. I guess there is one thing I'd like to point out, and that is that this ansa cervicalis right here, this loop right here, ansa cervicalis, there's input of many nerves, and actually it says there's input from C1 through C4, but there's also input from cranial nerve 12, the hypoglossal nerve. So not just the spinal nerves, but cranial nerve 12 gives input to that ansa cervicalis. And you can't see that here. Actually, I think, I can't tell if it's this one or that one. It's one of these two that's cranial nerve 12, and it has input onto the ansa cervicalis. So that's the cervical plexus, a blown up picture of it. Oh, 12 is right here, it's showing you. Here's 12. And you can see how 12 gives input to the ansa cervicalis right there. That's pretty cool right there. All right, so that's the cervical plexus. Another picture of the cervical. This is the collage of the cervical plexus. It's both pictures that were blown up, put together. And oh, by the way, look at this right here. C3, C4, and C5 keep the diaphragm alive. You can see that right there. All right, so that's the cervical plexus. Here's a blown up of the brachial plexus. Pretty complex. Actually, it's not. It's not that bad. There's a saying to remember, not that you guys have to. The next bit right here I'm talking about is really chit-chat. I'm not going to put this architecture on your test. But you can see how the brachial plexus comes out in roots, trunks, divisions, cords, and branches. And the saying is, Robert Taylor drinks cold beer. Robert Taylor drinks cold beer. So when you say Robert Taylor drinks cold beer, you're talking about the roots, trunks, divisions, cords, and branches. Now in lab, you're only going to learn some of the branches that came out of the brachial plexus. You're not even going to learn all the branches. I mean, the branches are the named nerves that we're going to learn, some of those branches. But this is how the architecture of the brachial plexus works. And you can see the roots coming out. You can see that right here. The roots coming out. And then you can see the roots combine to form these trunks. And these trunks are named based on where they're located relative to the axillary artery, which is in your armpit. So the superior trunk is above the axillary artery. The inferior trunk is below the axillary artery, and the middle trunk is between the superior and inferior trunk. But then the trunks bifurcate into divisions. And I just want to show you that they're intermixed. The superior trunk divides into two divisions that go to separate chords. And that's kind of cool because, well, I mean, it's kind of cool. It's kind of confusing. But the superior trunk divides into divisions that go to separate chords. The middle trunk divides into divisions that go to separate chords. The inferior trunk divides into divisions that go to separate chords. And then these divisions fuse to become chords. But as I just said, it's not a clean fusion. It's not like the bifurcation of the superior trunk refuses into a superior chord. It doesn't work like that. The superior trunk bifurcates and those branches go to different chords. Those two divisions go to different chords. And then the chords, we do have three chords just like we have three trunks. And the chords are the lateral chord, posterior chord, and medial chord. But they have input from bifurcations from different trunks, and the bifurcations themselves are called divisions. And now you can see why the myotomes aren't as clean as they could be, and it's because we do a lot of shuffling around in these plexuses so it doesn't stay clean. All right, so that's the brachial plexus, and you may or may not want to remember Robert Taylor drinks cold beer, but that is how you remember roots, trunks, divisions, chords, and branches. And just to be clear, I'm not going to test you on roots, trunks, divisions, chords. I am going to test you on branches because you learned them in lab. This is still the brachial plexus here. It's showing you some different branches coming off. This is still the brachial plexus here, and it's showing you even more branches coming off. And even more branches coming off. And here's the collage. It's showing you the brachial plexus with all of the branches coming off, so you can see all of them. And by the way, you don't learn every single one of these nerves in lab. You learn some of them, not all of them. Median nerve and ulnar nerve are two of the nerves you do learn for sure. You learn all of these: musculocutaneous, radial, median, and ulnar. You learn all these nerves right here, coming from the brachial plexus. And that's a collage for you. All right, the lumbar plexus. The lumbar plexus is T12 to L4. It's not showing you the entire thing right here. It's showing you part of it. These three nerves you do learn. You learn the iliohypogastric, the ilioinguinal, and the genitofemoral nerve. You definitely learned that in lab. So you can see that coming off the lumbar plexus. And this is the rest of it, all the way down to L4. And you don't learn the lateral femoral. You do not. That's not learned in lab, but you learn the femoral and the obturator. So you can see those nerves coming off the lumbar plexus. And this is the collage showing you all of them. Sacral plexus. You don't learn all of these, but you can see the sacral plexus right here, and you don't learn this one in lab. You don't learn this one. You don't learn this one. You do learn the sciatic and the pudendal. You definitely learn those nerves. And that's showing you a blown up picture of the sacral plexus and the branches coming down. The sciatic nerve is, you probably heard of sciatica before. This nerve travels right over your ischial tuberosity, and there's some muscles underneath it, or actually underneath it, superficial to it really. There's some muscles superficial to it that you've learned. The piriformis, the superior gemellus, the inferior gemellus. You learn these. And what happens is, especially if you're a man, and I don't know if I should have said that, it sounds sexist, but I don't mean it that way. I don't know too many women that put a wallet in their back pocket. So if you're a man that puts his wallet into his back pocket, what happens is you sit down and your wallet presses on those muscles and presses on these nerves, and it presses them against your ischial tuberosity right there. And that can make your leg go to sleep, by the way. And when you get up, you get the tingling in your leg. What you did is you compressed your sciatic nerve. Some people have a condition called sciatica, and this is an inflammation of the sciatic nerve. And with sciatica, you don't have to have a wallet in your pocket. Matter of fact, you don't even have to be sitting down. All of a sudden, your leg goes numb, and and it could be painful, by the way. It might not be numb. It could be painful. You have a hard time walking, and usually you got to walk it off and hope the inflammation goes down. Sometimes you have to take anti-inflammatory drugs for sciatica. So that's what you have to look forward to in your in your old age, you're going to get sciatica likely. Another picture, that's just an anatomy picture of all these nerves. And this is a big collage showing you all of those. Okay, big topic in this section. The neuronal pools. These are pools of interneurons we're going to be talking about. So let me remind you about something. You only have about 10 million sensory neurons. I say only, that's a lot of neurons, but it really is a little bit compared to interneurons. You only have about 500,000 motor neurons. So you got 10 million sensory and 500,000 motor neurons. But you have 20 billion interneurons, 20 billion. And these 20 billion interneurons combine to form pools, what we call neuronal pools. And there's only between 100 to 1,000 pools in the human body. And you're going to say, well, how come I don't know? That's a big difference. I don't know. We don't know all of the pools because some of these pools exist in the brain. And of course, we don't know everything about the brain. But 20 billion interneurons form between 100 to 1,000 neuronal pools. So what the heck do I mean by these neuronal pools? Well, here's what I mean. This is an example of a neuronal pool. This is called a diverging pool, where one interneuron talks to two or more other interneurons. So the signal diverges. And you can see that here, that the signal is going to diverge into other interneurons, so you can send it to different places. This occurs in the brain. This is sensory information going to the brain. And this is why sensory information can be processed on more than one level. For example, you step on a nail. A whole bunch of things happen simultaneously when you step on this nail. And that is, you say ouch, you pull your foot away, you, I don't know what else, but you do a whole bunch of things when you step on this nail. Well, how can you do all that simultaneously? Because the pools diverged and went to different parts of the brain. So that's a diverging pool. This is a converging pool. With the converging pool, more than one interneuron converges on one. This happens in breathing. The rhythmicity of our breathing is because of this. Oh, think of this, okay? You don't have to think about breathing. So one of these neurons is firing down through here, innervating this nerve, and that's going to your diaphragm through the phrenic nerve, and it's saying breathe, and you don't have to think about it. But if you want to think about breathing and you want to speed up your breathing, you can. Well, this nerve is coming from your conscious mind. It goes down to the phrenic nerve and it says, hey, breathe faster. So now your phrenic nerve fires faster and you breathe faster, or deeper, or slower, or shallower, however you are doing this. So you can have your subconscious breathing and you can have your conscious breathing. So that's an example of a converging pool. Serial processing. This occurs in the association fibers of the brain. Now, I know we haven't done the brain yet. 3 types of nerve circuits exist in the brain. Association fibers connect different parts of the brain within one hemisphere. That means they stay in the same hemisphere. Commissural fibers, by the way, I might as well spell these for you. It's coming up in a future chapter anyway. Association fibers, they stay in the same hemisphere, but they go from one part of the brain to another part of the brain, like the occipital lobe to the temporal lobe. But if they stay in the same hemisphere, they travel on these association fibers. Commissural fibers cross over between one hemisphere and another, so they go from right to left or left to right. Those are called commissural fibers. And then projection fibers go up into the brain and down out of the brain. So they're not actually connecting any part of the brain, but they go into and down out of the brain. And those are called projection fibers. Well, these association fibers are a serial processing circuit. It's just one neuron telling another neuron to fire. It's serial processing. And that's the third neuronal pool we've talked about. There's 5 of them all told. Parallel processing, by the way, you can see that there's some divergence here. So there certainly is divergence in parallel processing. So I'm not going to pretend there's not divergence. There is. You see divergence here. But after you have divergence, you send signals in a parallel fashion to different parts of the brain. And this occurs in reflexes and conscious responses to reflexes, because reflexes are an unconscious event. Well, let me say it like this. They're not unconscious. Reflexes can happen without consciousness, but when you're awake and conscious, you are aware of reflexes occurring. You know when the hammer strikes your knee and your leg kicks out. You don't have to know about it. Your leg would kick out anyway, but when you're awake, you do know about it. So these parallel processing circuits are involved in reflexes. This is a reverberating circuit, and this has everything to do with muscular coordination, probably normal breathing. So eupnea, we call it. Eupnea is normal breathing. So probably that, but muscle coordination is a big part of this. And it's a positive feedback loop. So what happens is this neuron tells this one to fire, this one tells this one to fire. Meantime, this one goes back and facilitates this one to fire, which makes this one fire more strongly, which makes this one fire more strongly, which makes this one fire more strongly. Meanwhile, you go back and you facilitate it some more. So this is a positive feedback loop, and this reverberation is likely also involved in your learning process. So that's the reverberation circuit. This was a collage of those neuronal pools of interneurons.